Hi, Kamal.
How are you doing?
Good, how are you?
Good. So, thank you for joining us. So,
Mhm.
today we are going to discuss HCC, RAF scores, and corrective claim process. And you are going to go through the process that we follow. This is the part that we use mostly internal education for our employees and also for our clients who may want to get more familiar with the process. So, I'll let you run it from here.
Okay. All right, let me know if you are able to see the presentation.
Yes.
Okay. Go ahead and put it into the slideshow. All right, does that look okay?
Yep.
Okay, great. So like you said, we're going to be talking about RAF score and corrected claims. So HCC stands for hierarchical condition category coding and risk adjustment factors. So this has been in existence for quite a long set of time. And HCCs are essentially used by Medicare and insurances to figure out the risk of a patient. There are sets of codes that get assigned a risk factor for a specific patient. So if a patient has no conditions versus if they have multiple conditions such as diabetes, morbid obesity, all of these are going to have a risk factor that the insurance then use to calculate how much that patient is going to cost or how often they would actually cause costs in the hospital. What we do with the RAFs and corrected claims is our care coordination team. So we have a team of nurses that goes in and conducts audits. They audit the charts, they look at all of the diagnoses and see if there is anything more specific that we could potentially add to that claim based off of the note that the doctor had already created. What we do on the revenue cycle team is we actually submit those claims as corrected after the nurse team identifies the errors. So as you can see here, over the last 3 years, we've definitely been doing this for a while now, and we keep increasing the number of audits and the number of corrected claims. So in total, there's been a lot. There's been about 37,000. But you can see that we did 5,000 corrections in 2021. We did 7,000 corrections in 2022. And at this point in 2023, we've almost reached the amount that we did in 2021. So as we continue to do these audits, we're definitely able to identify areas for improvement. I put a little blurb here about the specifics of, do you have hypertension or do you have hypertension with other issues? So it's kind of like, did you get a new car or did you get a specific type of car, like a Tesla? This explains it a little bit better. So this is capturing the risk. You can see that there's a patient here who has diabetic polyneuropathy, morbid obesity, and congestive heart failure. If you combine all of those diagnoses, you get a risk score of 0.427. However, when we look at all of the issues that the patient actually has and make sure that they're coded to the highest level of specificity, we can see that there's a couple more specific things, specifically congestive heart failure. When you add all of these together, you actually get a higher risk score of 1.325. What's important here is that the patient's diagnoses didn't change, but the coding and the documentation of it did. And this lets the insurance know that this patient is actually a higher risk than if we would have just coded it this way with diabetes, hypertension, morbid obesity. When we give in these polyneuropathies and the congestive heart failure and the BMI, it really paints a better picture of the patient's current health. This is an example of what our work would look like. So here we have all of the diagnoses. Originally, the provider had billed 6 diagnoses on the claim. But upon review, our nurses identified that F32.0 was able to be billed as well. 2 out of the 6 diagnoses had a RAF score affiliated. And in addition to the 1 new code being added, 1 of the 6 diagnoses was able to be updated. So just by looking at this one patient, we were able to make a significant change in the documentation on these patients' issues. So what does my team do? Like I said, after the nurse team goes in and actually audits this and looks at the diagnoses, we submit a corrected claim to the insurance. So this is not a real patient. This is just a test account for me. But I gave examples of if I had hypertension and kidney care or kidney disease. If you have both of these in conjunction, it actually does change the diagnosis. And so we would go ahead and recode that, and we would submit that as a corrected claim. And just by doing that, we are telling the insurance, hey, this patient has significant issues, and it's not just two separate illnesses. It's something that actually causes a higher impact. So how do we optimize this? We all work together as a team. We have a solid understanding of the HCC ownership at all levels. We make sure that the appropriate diagnosis coding is at the highest level of specificity. So again, do they have diabetes, or do they have diabetes with polyneuropathy or anything else? We want to make sure that the clinical documentation supports that. That really is the most important thing, to make sure that our notes are reflecting the accurate diagnosis for the patient. Effective data management and effective flow management. So we work all together to make sure that that goes into effect. And what does that actually mean? What does that translate to? So really, when we are reporting the correct risk score, we're improving the patient care because we're accurately reporting their issues. It leads to increased revenue and increased staff satisfaction. So taking a look here, we have two different groups. Group 1, where that risk score was less than 1.2, and here where it's between 1.2 and 1.5. Based off of that risk score, you can see how much the insurance is really investing in these patients, that they really are going to end up probably going to the doctor more often, or potentially using emergency services more often. So the insurances do recognize that when we're accurately describing the risk of the patient, it does translate into more population-based care. And that was my last slide. I can stop sharing. Any questions?
Well, Katie, thank you so much. So now, what you presented for us today is one of the ways to see how a medical billing company can evolve from a medical billing company to an advanced RCM, revenue cycle management company. So in today's medical practices, especially private practices, which our client demographic is, what we understand is the compensation model is not going to stay the same. Compensation used to be for medical offices based on fee-for-service. So you would see X number of patients, you would build certain level of codes, and then that's how you would get paid. Today, almost 20% of our income, our compensation is depending on value-based contracts. United Medical ACO has almost 8 different ones with different insurance companies. And in order for us to not to get a pay cut for our clients, we have to max out this 20% today. So what I also see in the future is the 80-20 distribution probably is going to be getting a little bit heavier on the value-based side, because now there are dual risk contracts where practices are taking risk. If there are any loss, then they will be liable. So that makes it, that emphasize the quality and value even more for the future. So that's why for us, from the medical account receivable standpoint, and from the offices who are entering charts, from the physicians who are entering initial charges, and what diagnosis we use, how we use it, when how frequently we use. This all becomes a big part of how we get paid today. So what United Medical build for our clients is, from the central office, several nurses who are on the clinical side trained to do the writing. They actually do the chart reviews, and this process started with the help of revenue cycle management side. So now we don't want to lose, we don't want our clients to lose any income for the program year. So And I believe it's working so far. So this started in late 18, early 19. One of the challenges that we all know, we all see is, for example, Medicare, their risk score follows about 2 years behind. So what we have done 2 years ago is going to reflect today. What we have done last week is not going to reflect until 2 years from now. So when you have to work in different dimensions, time-wise, then you don't actually see and you don't kind of connect these benefits right away. But the big issue, and I believe what we do as an accountable care organization, as an RCM company, we are closing that gap and then trying to maximize the income, the revenue our clients can generate. So, and your examples were very nice for our employees to understand. But also, if someone out there who has a medical private practice, some doctor with 3 other partners, and they didn't know about it, chances are they don't know about it. So then they are losing 20% today. So I also want those individuals to watch these events and understand better how they get paid. Your compensation model is changing, and that's why you have to adapt and you have to have good service companies in place to help you to maximize your compensation. So, Katie, again, thank you so much for joining us, and I'm sure we'll have you again in the next couple of months. It's always more fun when I have you guys joining, and also now I'm also learning from you guys these days, so that's even better. That makes it even more enjoyable. Thank you so much again.
Thanks. Have a good day.